No, it's not actually.
Your hair's actually not either.
Okay, so you guys do not need to move this at all. I don't know why the last class did, because you have gravity and you have both of these springing metal pieces holding it into place. It's not going to move. Okay. And then the other thing is you're going to want to get your SID set to 40, and then I'm going to line up my tube to the bucky. Because your bucky's going to get maxed out down here, so you might not have enough room necessarily. Actually, I do have a little bit, so I'm going to move this down so I don't annihilate JP and Crystal. But just make sure this system is set up first, okay? If you have that done, you don't need to touch it again, okay? Yeah. If you're going to throw an angle, do the angle and have this match to this. Now you guys are free to just focus on your patient, okay? So for Jessica, you guys might want to kind of in the line of fire. You're going to want to make sure that the central ray is at the apex of the patella. Which is this one? This is the AP non-weight bearing, yes. Knee. So it's at the apex of the patella. And then for patients where their hips are less than 19 centimeters, you would angle 5 degrees caudal. If they're greater than 19 centimeters, not 19 degrees, 19 centimeters, then you would angle towards the head, cephalic. If they're average, basically right at the 19, then you would just go straight on.
So they have like bigger.
So it's like 7.5 inches, and then I think it's what, 10 inches, right?
Yeah, because it's 2.54 centimeters.
Yeah, so it's like
8,
I can't centimeters,
Wait,
so
no.
that's what I'm trying to explain.
Right now it's closer to 9.
Is
well,
it?
actually, no.
So it's like 7.5 is
you're right.
below 19.
So bigger thighs.
Yeah.
5 degrees.
Mm-hmm.
Okay.
So if they have a nice booty, you're gonna add a 5, about a 5 degree angle. Okay.
No booty, you go down. Right.
Right.
Yeah, and negative booty, you go the opposite direction.
Mm-hmm.
Okay.
I'm literally running that 5 degrees for a big booty.
I think 5 degrees for any booty.
Bottoms up. Bottoms up.
Exactly. Okay.
5 degrees caudal for no booty. Got it.
You have a big bottom. Bottoms up.
Bottoms up. I like that, Matt.
Yeah.
All right.
If your wife ever sees your notes.
I know.
Yeah.
I cannot study around her now. She'd be like, what are you doing at school?
Okay, so now I'm going to have you rotate. We're going to do the internal rotation or the medial rotation. So you're going to go 45 degrees. So I'm going to need you a little bit more. Right there. And if your patient can't turn like Jessica's able to, you can always have them roll onto their hip. The only issue is if they start rolling onto their hip, you're going to create more OID. But you're at the mercy of what your patient's limitations are. Okay? And then now I'm already set up. I don't need to worry about anything, except maybe I'll just move Jessica a little bit so that the centering is a little bit better. Okay. But that's the beauty of having this set up to your bucky. You don't have to worry about it. It's just tabletop motion. Okay? All right, so that's your internal rotation. What do you guys think you see on this one? You can relax, Jessica. Or what would that position be best for?
Tip fib.
What about it?
The head. Yeah.
Of what?
Fib.
So you get the proximal portion of the fibula isolated from the tibia.
Oh, okay.
And so that's why that view is so good, because there might be a little fracture on the tip of the fibula.
Yeah.
And you can't tell if they're superimposed.
And usually they're always, like, no matter what, a little bit at least superimposed.
Right, except for this view.
Okay.
So usually if it's like a 3-view knee and it's in the ER, it's always the internal rotation over the external rotation.
Oh, okay, interesting. I've never done an internal before.
So is that just called internal rotation, or is it like internal oblique, or how do they?
Oblique. Yeah, there's
all of the above.
Yes.
Yeah.
Or medial rotation, medial oblique.
Yeah, I've
You're
heard
gonna
that.
you're gonna see all that.
How many degrees would you rotate it? Would you say like 15 to
It's
20?
45.
Oh, 45. Okay.
Yeah.
So you okay.
So it's like a true oblique from the 90, just halfway.
Okay.
Okay. Now I'm gonna have you rotate your leg towards me. This is the easy one for patients, a little bit more, yeah. So now we're gonna be 45 degrees the opposite direction. I'm just gonna move the central right over a little bit, so I'm centered a little bit better. And that's your external or lateral oblique, or rotation, whatever you guys wanna use. But all of those terminology might be seen on the test, okay?
And then our angle still, we don't move that.
It's gonna
It
be
stays at
5
the five.
degrees, it all depends
Yeah.
on the booty, but
That's
yeah,
for AP external and internal, right?
Yeah.
yes. Alright, so you can relax. Now we're gonna do lateral, so I'm gonna have you roll onto your side. You're gonna swing your right leg in front of your
Why
left.
do we do it like this? Because I think this is so uncomfortable. Like when I try and get patients to do this, it's not like it's easy for them to, like, this isn't like an easy position.
Yeah, sometimes I'll just do cross table.
Most we
It's
do
like
cross
this
table
is-
most of the time, but every once in a while when I have people do this, I'm like, this is not easy for anybody, let alone somebody who's injured.
Right, I've had
Okay.
elderly patients that tell me, you know, they didn't sign up for my yoga class.
Right.
So I thought it was really funny that they said that, but
Because I feel like it'd be easier to put your leg behind you.
the issue with that is some people have really big tissue or like a lot of tissue on their legs, so if they go behind, it still overlaps, and then that would be.
Because that's what happened the other day is the lady put it in front and she couldn't get it far enough in front. Like at clinicals, my lady couldn't get it like this.
Yeah, okay.
Yeah. I think
Was
I've
she,
always
like,
done
bigger?
cross table.
No, she
Yeah.
was just
Always
hurt.
been elevate the
Oh,
leg.
yeah, if they're that injured where they can't move, I do cross table every
Okay.
time. Because I would
Yeah.
treat them like a trauma.
I
Okay.
They
think
don't
I've
know
always
what's
done
going
cross
on.
table.
Yeah.
More.
And then for this one, oh, not yet. You're getting too far ahead of me, Jessica. So you are going to be making sure the knee is bent about 20 to 30 degrees. You don't want any more than that because what happens is the patella gets brought down against the femur, and you won't get a good visualization of the joint space between the patella and the femur. Okay. So now, yes, 20 to 30. So it's only a slight bend, so I'm going to have you bend a little bit. Okay, let's bend a little bit more. So let's say we bent this much and then we saw the patella, there's like no joint space. That should tip you off that you had the knee bent too much. And so we're gonna bend a little bit less right there. Okay? Another thing I'm gonna do is I'm gonna put this under Jessica's foot. Thank you. Okay? And if you're in, like in the ER or somewhere like that, you can get just towels. I'll just bunch up towels, roll them up real tight, and throw them under the ankle. So your medial condyle is a little bit lower than the lateral. It's about 5 to 7 centimeters lower than the other one. So what we have to do is you do a 5 to 7 degree angle cephalic, okay, to make up, and that's how you get both condyles completely
That's
superimposed.
if we don't put something under their ankle.
I do both.
Oh, okay.
Sometimes it might hang down a little bit more, and so I found that if you put something under their ankle, it helps level them better, and then it also stabilizes your patient. So I usually have a lot of success when I do it this way. And then you're going to be putting the central ray about an inch below your medial condyle. Okay?
How come they don't angle at Kaiser for lateral? I feel like I never see them angle for it. That's like a standard thing, like you're supposed to angle it.
If they have any kind of booty, yes.
Yeah.
So
I see.
unless they're like really skinny, like
Yeah.
stick skinny, that's the only
Right.
time I've not angled. But
Yeah.
I would say for me, I angle on almost every single patient.
Oh.
There's very few patients that I don't angle for.
Okay.
And I've never had it angle the opposite direction.
Yeah.
There's an instance where I would, but I'm not gonna go there because
Yeah.
I don't need to confuse you guys.
Okay.
All right. So I'm gonna have you lie back on your back.